Well, I have to be a little bit quick because there were some problems about the time limit of my presentation. So I'm going to be quite fast. This is a complicated topic, but I try to bring an example to you. Of course, classification in psychiatry is an old problem. Are we going to have the categorical classification, or are we going to have a dimensional classification? And no matter what we do, still we will have some red place where we have the classification. So in the end, we are going for categorical classification, be it in the syndromal phase or the symptoms phase. Well, one of the examples is schizophrenia. There are so many symptoms and signs, but we do not see the same signs in all of the patients. And sometimes with very few of the symptoms, still you can make the diagnosis of schizophrenia. And it is not possible to ask the location in the brain about these signs. Let us talk about the symptoms. For instance, we are talking about the repetitive thinking or ideas, for instance, focused ideas, rumination. So you think about the same things over and over again, and in the end you lose something. Another repetitive thinking is the excessively or overvalued ideas. For instance, a person is a fan of Fenerbahçe football team, and if you talk against Fenerbahçe, then he's going to be obsessed with that idea, and he's going to think about Fenerbahçe the whole day. And obsession is going to be dealing with the same situation throughout the day. And also this delirium is going to continue like forever. So you are focusing on the repetitive ideas or repetitive thinking, and when you think about the brain, we have the basal ganglia, frontal area, but you may ask that the rumination and delirium is not the same. Yes, they are not the same. Yes, they have the repetitive thinking, repetitive ideas. Pathologies are more or less in the same places, but then the nature of the symptoms are different. Still, I am not very pessimistic, because there are young and ambitious people who are working on this issue, and also there are brilliant and experienced people working on this. I think the criticisms are quite harsh, and for the classification we are going to see the RDoC parameter, and we are going to see whether it's going to change the paradigm or not. No matter whether you like the United States or not, NIMH is the strongest place or the strongest institute to identify this. And we are also producing so many studies. In socket studies, for instance, in one of them, our colleagues are working about these on these artifacts, and they are trying to get rid of those artifacts, and they are working day and night. This is one of our assistants, residents. Çağdaş Kaya is the computer expert and our technician. And in the 3 Tesla MR, we have people working day and night. So in the end, the neuroimaging is involved in this process, in a way. And in the neuroimaging, we started to collect so much information, but we are just absorbing them very recently. And when we are lecturing, we were saying that these are disorders, the causes of which are not known. But there is one exception, which are depending on a certain organic situation. For instance, in the substance abuse, the reason is the substance. Then we know the reason. However, now we have a different approach. So we regard the substance abuse as a result, as a conclusion, because there are some issues that are motivating that person to use the substance. So, for instance, when we say disorders related to substance use were in DSM-4, but for the first time, a non-chemical substance use is included in the addictive disorders. And DSM-5 is the substance use and addictive disorders. So, what is substance addiction? Well, in Brookhaven, I worked with neuroimaging on this substance addiction issue in my PhD thesis. And we are talking about a certain behavioral pattern, and neural changes are taking place. One of them is tolerance. Tolerance is not just taking the substance to in more amounts. We are talking about the loss of effectiveness on the reward system, and also we have the withdrawal syndrome, and we have also the cravings, because that is the main issue that is motivating the person to go for the substance. For instance, a cocaine addict would just crawl down to just find one piece of powder cocaine on the floor. And also we have the disinhibition, the lack of control on substance abuse, and in addition to that we have tolerance and withdrawal symptoms, although they are not absolutely present in all of the substance addicts. So these were chemicals, so it's easy to explain withdrawal, it's easy to explain the cravings and everything. But what about gambling? So, of course, we are talking about addictions like to sex, computer, shopping, etc. But gambling is more evident. Well, what is gambling? You are risking a certain value in order to gain more. So you have a hope to gain more, and that's why you are risking the things that you have at hand. And what is the situation of gambling in DSM-5? There is a criterion that at least four of the following items should be present in the last 12 months. That is, the anxiety should continue in a gradual increasing way. And also, there should be restlessness when the gambling behavior is tried to be stopped or reduced. So this is the withdrawal, actually. And you can fail in reducing or stopping gambling. So the brain is always involved in gambling. So this is obsession. I think there's a very dramatic substance in the, it's a dramatic sample. For instance, in substance addiction, we think that that person is not doing anything, but the whole day the person is thinking about how to get that substance, and also they have the feelings of guilt and some restlessness, and there is also an increasing desire for gambling. And also we have the distortion of the decision-making mechanism, because they need to make compensation after a material loss, financial loss. That is the difference between the professional gambling and pathological gamblers, because professional gamblers still have their decision-making mechanisms, because they do not go for abundant or exaggerated risks. So, in the substance abuse and addictions, and when we look at the parameters of the gambling, we can say that, like phencyclidine, the gambling is covering those parameters, those criteria, sometimes much more than the substance abuse. And all the symptoms are covered in gambling. So, what does this substance do? Particularly if when you are faced with a reward for the first time, dopamine increases. We are talking about natural rewards like food, beverage, sex, protection. These are primary reinforcers, and dopamine is increased as a result of these rewards. However, if if you're comparing this to a different substance, for instance, you had pleasure in this hotel, and whenever you have the idea of coming to this hotel once again, you can still have the increase in dopamine. So if you just see a related substance or related issue, then you can still release dopamine. And if you do not get that, then there is no dopamine release. So, for instance, alcohol is not primary, but it's secondary. And you have the alcohol as the reinforcer, and you have the nice glasses for wine. And whenever you see a nice glass, you would think about wine. And even if you don't drink the wine, your dopamine is increasing. What does it cause? It leads to craving. And this is the main mechanism, because you are going to act if you think that you're going to be rewarded. So whenever the person sees a cue for that, the dopamine is started to be loaded and charged, and the person starts to crave for that substance, and it is actually the cause for losing inhibition. These are the slides of Nora, actually. Some of them are in English. So, what is the factor that is changing our understanding and mentality? One of the most important points is that as the dopamine increases, the pleasure is also increasing, but it should be increased fast. I mean, it should not be slow. So, whenever the dopamine is increasing fast, then the pleasure level is increasing. This is one of the characteristics of dopamine. When dopamine is peaked, then all the cues and all the other related items are in the memory. So amygdala and hippocampus are activated. So whenever you see white cheese, you think about rakı. For instance, when you talk to the alcohol addicts, they would always be talking about how much they drank and how pleasurable it was, because those talks are increasing their dopamine levels. But natural substances or a primary reinforcer cannot increase dopamine as much as the substance do. Therefore, dopamine is actually attributing a great value to that substance. But the main problem here is that we know that dopamine is increased. And also there is a great pleasure if the dopamine is increasing fast. But in long-term use and in substance addicts, what happens when you give the substance? The person is having pleasure, but the dopamine release is less than a normal person in drug addicts or substance addicts. So they release dopamine less than the normal controls. For instance, in normal people and to the addicts, we would give metafeminate, and the normal people would be very disturbed about this, because euphoria would be enormous, and they would just stand up from PET. But the substance addicts were quite happy with that. This is the first thing. And second thing is the dopamine receptors. Because dopamine 2 receptors are also lower in these people. We don't know whether it was lower in the beginning, or is it getting lower as time passes. And when we looked at the PET dopamine 2 receptors in children of the addicts, we can see that the D2 receptors are decreased even if they are not faced with dopamine yet. maybe the effervescent substance is looked for by that patient, because the dopamine inhibition is not so evident in these people at the beginning. So in fact they are not getting so much pleasure, but the main thing is craving. So they are having problems in the inhibition centers. This is the vitamin study. For instance, the cocaine addicts do not make the assessment about the money, even if you give money to them. And in the anti-cingulate cortex is hypoactive. When it is becoming hyperactive, when they are exposed to films, videos about cocaine, then cingulate cortex and orbitoforbital context is hyperactivated, and the reason for that is craving. And if the dopamine receptors is higher, then the craving is higher, and then amygdala is also very interesting, and reflexive reaction is seen. This is the study of Childress, and physical and visual pictures are shown to the person, but these are shown in 33 milliseconds. So these are covered pictures. So only neutral or aversive pictures are shown to these people. And one of them is primary reinforcer, and one of them is the secondary reinforcer. And amygdala is activated, and dopaminergic system is activated as a result, and then the person starts to crave. So even if you don't see the cues in some cases, if you are an addict of a substance, then you are just craving for that substance, and sexual arousal is also as a result of that. And in dopamine, in a male, dopamine is more activated, and that is why men cannot think very well whenever they are sexually aroused. So in summary, we have the lower dopamine release for the natural stimulants, and also there is the decrease the D2 receptors, and particularly the inhibition centers do not work very well. Decision making mechanism is not working very well. What do we see in gambling? In gambling, if you, for instance, know the result, you do not release dopamine, secrete dopamine so much. But if the level is about 50%, then you get activated. And the highest rate is when the losing and winning rate is about 50%. So, and if you have a tendency to that, predisposition to that, then the situation changes. Because orbitofrontal, in the orbitofrontal cortex, as I mentioned in the morning, those two systems and striatum are working very close to each other, and lateral and prefrontal cortex are activated, and in this area, actually, you lose the function, and you overvalue that issue. And normally, if you think that it's misleading, you would avoid this. But what happens in the substance addicts? The substance addicts are taken to fMRI, and there's a task in which they will have 50% of chance of winning. So you are going to pull a card, and if it is red, you will win. If it's not red, you will lose. What happens in both normal people and drug addicts? The striatum is activated. However, in substance addicts, you can see the difference here. Dopamine release is less. But there is one more difference, which is in the medial prefrontal cortex or orbitofrontal cortex activation is different. That is, the value that is attached to that process is changing in that person. Therefore, the person gets more sensitive to dopamine. Just like in the substance addicts, in gambling disorder, according to DSM-5, they are actually having the same manifestations. And the prefrontal activity is less. So when we give some cues to the gambling, just like in substance addicts, again the activity in the amygdala is increasing, just like in the substance addicts. So if a person has gambling disorder, if he sees a cue for gambling, then dopamine is released and craving is achieved as a result. There is also the decision-making mechanism. So you lose the money, so you should leave the table, right? No, because the dopamine is released more and more. So this is a reverse learning test. For instance, you select on the right or left-hand side, and you are trying to, you are winning something, and then you change it, and after a certain period of time, I mean, once you are wrong, you need to change, but you need to switch your option. But in winning or losing, you don't see the activation. So the people are not aware of the detriment or harm that is caused by this loss, and that is why the reprimand is not possible, or it is not valid for these gambling disorders. And also we have the assessment of the money. For instance, do you want 10 TL of today, or do you want 11 TL for 1 month later? That is why the banks are using this in credit cards. So the gamblers are asked, so we are asking this, should we give you 20 euros, or with 28% of possibility of 50 euros? And all the gamblers choose to wait and to take the risky one. And the neuroimages are active. I'm being very quick because I have limited time. So when we use neuroimaging during the natural stimulants, there is the decreased dopamine release both in substance addiction and gambling, and also there is a less dopamine release in substance addict and gambling. There is decreased D2 receptors. In the substance addicts it is present, but in gambling we do not see that. Craving is seen in both of the situations. Inhibition centers do not work very well, and also the decision-making mechanisms are not working very well. In conclusion, we can say that the substance abuse was seen as a lack of will, but the biological basis are shown as a result of neuroimaging techniques, and I think DSM has done it very well in a correct way. So the gambling and drug addiction are included in the same category, and it is for the first time showing that the neuroimaging is used also in the non-chemical behavior and its effects on the brain. And it can be related to similar pathologies. Thank you.